I think my goal is to have the scoliosis have like zero impact on the patient's lives. The brace, big impact. Surgery, medium impact. If I could wave the magic wand and make all the scoliosis go away. That's my goal.
For decades, treatments for scoliosis have remained limited, but recent advancements have opened the door to more options. One innovative breakthrough straightens the spine while maintaining its ability to bend, flex, and grow. Today, we're speaking with two experts who have developed a decision-making tool to make it easier for patients to choose between the different scoliosis treatment options. That's ahead on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Wurzer. Thanks for being here. Dr. Noelle Larson is with us. She's a pediatric orthopedic surgeon at Mayo Clinic. She's also a professor of orthopedic surgery specializing in scoliosis and pediatric spine conditions. Also with us, Michelle Marks. She's the executive director of the Setting Scoliosis Straight Foundation. Its mission is to support discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide. Together, Dr. Larson and Michelle developed a decision-making tool to make it easier for patients and parents to choose between different scoliosis treatment procedures. It's such a pleasure to have you both here. Thank you.
Yeah, wonderful to be here. Thank you so much.
Thanks, Kathy.
A pleasure. Say, Dr. Larson, I don't know if my definition of scoliosis was that great. How do you tell patients about scoliosis, and how common is it?
I think you did a perfect job, Kathy. We don't really understand why most patients get scoliosis, but it seems to show up predominantly in girls during the teenage growth spurt, and a normal spine, for some reason, starts to grow into a curved fashion. If we catch it early, there's non-operative things like bracing or even therapy that can help, but the more severe types of scoliosis sometimes require surgery.
If not treated, what are the effects?
We think the really large curves can go on and continue to progress throughout life. People with scoliosis on average in adulthood have more back pain, and the very severe curves can actually start pushing on the lung and even the heart and cause breathing problems.
We've heard the word watchful waiting, that term. When does watchful waiting and treatment begin for a patient?
For the most part, for scoliosis, we're assessing it typically by an X-ray. For early scoliosis, we can do a physical exam and see some asymmetry or almost like the rib cage becoming more prominent, and that can prompt the X-ray. Back 10, 20 years ago, there was a lot of school screening and scoliosis was detected early, but now due to different cutbacks with school funding and different data showing that maybe we were X-raying too many children, the rates of school screening has decreased. And so oftentimes people are coming in and the mother just noted one shoulder blade a little bit more asymmetric. I've had children who are swimmers or gymnasts where a teammate actually notices the scoliosis. And then frequently it's picked up in school physicals or sports physicals. But not every teenager is going to the doctor on an annual basis. So I think this is resulting in more cases of scoliosis showing up in a delayed fashion where it's too late for bracing.
Can we talk a little bit about some of the treatment options? You mentioned bracing. Michelle, can you explain that for folks?
Yeah, so when a curve is small enough to have a brace be utilized to correct the curve or stop the progression of the curve, it's fitted by a person called an orthotist who specializes in making scoliosis braces. And like Dr. Larson, she would be very involved in that type of brace to be chosen based on the type of curve that a patient would have.
You have a prop. I have to see your prop, doctor. Okay, so that is a brace and it looks really uncomfortable. Oh my goodness. How do you describe that, doctor?
We call it a TLSO, so thoracic lumbar sacral orthosis, but it's plastic. And then there's quite a bit of variety. Different braces look different ways, but we call it rigid because it does not bend. And then basically we custom fit the brace. We strap these tights, the straps are basically as tight as you can get.
I can hear them jingling. Yeah.
Yeah. And then we get an X-ray in the brace to make sure that the curve looks better.
Wow. I can see where that would be difficult for a young person, perhaps, to wear this brace for long periods of time.
The amazing thing is I have children that do it. Like I've had children that have grown up in one of these, which is amazing. But so I don't think we should discard the bracing. And there are other groups that are working on the brace and trying to build better braces, but this is the industry standard right now. It's custom made to the patient. And we basically mold the patient either with putting a cast around the child's body, or sometimes we will do a scan of the child, like a 3D scan. And then it's a plastic brace. Our typical one we use at Mayo has buckles in the back. So the children kind of buckles themselves into the brace. It goes from your armpits up to your hips. And the goal often is to wear these braces 16 to 18 hours per day. And many children have to wear this brace for years. Typically, it's like 6th to 8th graders. But it's quite a commitment to wear the brace to school, to find clothing that fits around the brace, to wear the brace at night and take it to camp or take it to slumber parties. There's a wonderful study out of Iowa where they randomized children to the brace versus no brace, and they actually stopped the study early because the brace was found to be so effective. So the brace works, but it's hard to do. And the interesting thing is some people do a great job with brace wear. Like I've done a 30-year follow-up study of scoliosis, and the people brought their braces 30 years later. So there's children that were treated at Mayo like in the 80s, and I've seen them at 30 years, and I've seen them at 40 years. And one of my patients actually came back to visit her brace because I have it in my office.
I can only imagine. I mean, Michelle, we're talking about young girls mostly, right? And there's always this kind of social anxiety. There's body image issues when you are young. What about that part of bracing might be a little difficult?
Kathy, it's incredibly difficult. I mean, picture that time of a person's life. I mean, it's so challenging. And to add that level of complexity with needing to pick out clothes to hide the brace or to make someone feel comfortable or pretty, having the brace on is a huge challenge. And, luckily we have so many scoliosis ambassadors who volunteer with our organization who share tips and tricks and ideas on what to wear and how to go about being successful in your brace wearing.
Michelle, do you have any personal stories in your background of young people who've developed scoliosis?
Yes, I used to practice as a physical therapist at Rady Children's in San Diego and treated a lot of post-op spinal fusion patients and really developed an interest in scoliosis research at that point.
And I bet you work to help patients not see themselves as a person with scoliosis, right? Just a kid, an active kid. Does that make sense?
Yeah, for sure.
My favorite is when the patients come back 2 years or 5 years later and they're off to college, or they're going to state championship, or they have some activity they love and they've forgotten about their scoliosis.
Or the opposite, where they take their experience and then they want to pay it forward. Like we have so many wonderful volunteers that are through their treatment, but yet they want to now share advice, expertise with the next generation of patients.
But we'd love to take the stigma out. I think there's a little bit of stigma about scoliosis and words that have been used about people with scoliosis. Many of the teenagers are shy and don't want to talk about their brace. So we'd like to help the children come through the experience with more self-confidence. And as Michelle said, willing to volunteer, to give it back, to help the next generation of children going through the treatment.
And just to get it out there on social media. I mean, this is where this age group lives, right? Eats, lives, and breathes all day long. And putting information and education out through our social media channels takes that stigma away in a way, makes it a little more understandable and acceptable.
I want to introduce you to an amazing young woman. Her name is Sloan, and she was diagnosed with scoliosis back in 2018 at the age of 11. She developed a rapidly progressing spinal curve, and her only initial treatment would have been wearing a brace all day. Her mom found an alternative in a VBT clinical trial, and thanks to that procedure, Sloan is now pain-free and has returned to competitive horseback riding and figure skating. So when you got that diagnosis, Sloan, what were you aware of? What did you know and understand about what it meant?
When I first got my scoliosis diagnosis, the only thing that I really understood about it was that there was a curve in my spine. You could see it. So I was like kind of twisted back like this, and my shoulder was dropped. And then when I would bend over, I had this huge hump on my back. And girls at school and at skate camp and stuff made fun of me for it. And I mean, that was kind of the biggest achievement was after I had surgery, I had no hump. But yeah, I mean, when I first got diagnosed, it was very like seemed like no big deal. Like, oh, they test this for you in middle school. Like it can't be that big of a deal.
It's clear from Sloane's story just how life-changing scoliosis treatment can be.
Well, it's a big thing. And, it's not cancer or life threatening per se at the time, but to that patient and to that family, it's life changing. And going through either a surgery or years and years of bracing it takes a toll, and they need support, and they need to know that there are incredible professionals like Dr. Larson and our group of surgeons that are spending all their free time trying to advance care in every way they can for patients with scoliosis.
When does surgery come into the equation?
Basically, less than 10 degrees is not scoliosis, or monitoring 20 to 40 degrees, patients are a candidate for bracing. And then somewhere that line between 40 and 50 degrees, these curves take on a life of their own and the bracing is no longer effective. Typically, the cutoff for surgery was 50 degrees. I'd say until recently, that was our real goal, our real guideline. But we take other things into account. We take into account how much pain the patient is having, if they're having pain, how much growth the child has left. So if the child is still growing, the curves can continue to get worse and are harder to brace for, say, a 40 or 45 degree curve. And I think also the patient's image, like when the child comes in to see me or the teenager comes to see me, I ask them, how do you feel about living the way you are now for the rest of your life? Is this an acceptable way to live? Are you comfortable in your body? Are you comfortable with this curve? And often that decision for surgery involves a level of discomfort, either with how you feel or how you look, or the concern about what the future holds, if this curve is going to continue to get worse and be a lifelong problem.
And is the repair spinal fusion?
Until about 10 years ago, that was our primary option. And for many curve patterns, that's still the only option. So unfortunately, children with an associated neurologic or neuromuscular condition like cerebral palsy or children with spina bifida, we don't really have other options other than fusion right now. So fusion surgery is usually an incision in the back, and I have a little handy dandy spine. But basically your spine, again, runs up and down the middle of your back. And the fusion has been around since 1970s, late 60s. Basically, we make an incision, move the muscles out of the way, put in rods and screws, and then we have really sturdy, powerful correction of the scoliosis. In most instances, we're able to get the spine like completely straight. And then we roughen up the bone, and that creates like a healing response. So the body forms a solid sheet of bone. And this works pretty well. And most kids do pretty well with it. And that was all we had till about 10 years ago.
That's quite a journey to take to have spinal fusion surgery, Michelle.
Yeah, it is a big deal. And patients and their families are often really concerned about what that perioperative course looks like, what that postoperative recovery looks like, and giving them the best evidence-based information regarding those concepts, and that experience that they may or may not have is really, really important and gives them a lot of relief going into this decision-making process.
So, doctor, the spine needs to be immobilized in a sense, right, in order to have it straighten up. Is that what we're talking about when it comes to spinal fusion?
Until recently, really the fusion was what held the spine straight over long periods of time. And we had other things out there like growing rods, but all of the other treatments ultimately ended up in a fusion. And surprisingly, most patients do really well with a fusion. I think the downside is really if your lower back is fused, or if you're very athletic or want to pursue future athletic activities like triathlon, gymnastics, backflips, your spine becomes stiff after the fusion. And so I think parents really struggle with this. They struggle with the concept of their 10 or 11 or 12-year-old needing to have their back fused because it's such a permanent decision. You can't undo it. And I think this is really the interesting piece here, that now we have new options when is the new option ready for your child?
It's one thing to discuss it, but to hear it from someone who has lived it is something else. Let's listen. So you were just 11 years old, I understand, when you were diagnosed with scoliosis. Do you remember how it was discovered?
Yes. So obviously being a very active kid, I would need like therapies and stuff. But my mom would rub my back, just rub my feet, make sure I'm feeling okay. And she was rubbing my back one night, giving me like a massage, and she noticed that the left side of my back had less muscle definition than the right. And my mom is a healthcare worker. She's a healthcare administrator. She kind of knew. She had this sinking pit in her stomach that she knew that I had scoliosis. So we went to my primary care doctor I think it was even the next day. We went in, we got an x-ray. My curvature was at 15 degrees, was my primary curve. At that point, I did not have a secondary curve. That was in March of 2018. At that point, we scheduled an appointment at the Children's Hospital. And then I went to the doctor there where he laid it out for me that I was going to be braced. I was going to have a fusion when my growth plates closed, and that my spine would be fused. I would never move my back the way that I needed to be the athlete that I was again. Me and my mom walked out of there completely defeated. We got to our car, we sat in the parking garage, and we cried for an hour.
So, as an athlete, did you feel any difference in your back when you were moving?
No, when it started, I didn't feel anything. I wouldn't say that I even noticed I had anything wrong with me until my Cobb angle was probably 45 degrees. It never bothered me. It never hurt. It never inhibited me to do anything. I mean, I competed through that season of figure skating and rode horses up until 2 days before I went down to Rochester for surgery.
Wow. Oh my goodness. Okay. So you go through all of this. Obviously, those treatment options that you were presented with at first, I mean, I can't imagine your shock.
Yeah, when they told me that I was going to need to be in a hard plastic brace for 23 hours a day, and then they were going to stick 2 metal rods that ran almost all the way up my spine, all I could think about was the fact that I need to bend my back to do hydroplanes and figure skating. I need to turn my spine to look at the barrels and look at the cattle when I'm riding. I couldn't be fused like that. It almost made more sense to just let it take its course and not have surgery at all and possibly be forever disabled.
You actually consider that with your mom?
No, mom never did because she knew she was going to find something. But in my brain at 11 years old, I thought, well, at least I could finish high school.
Oh, wow, Sloan.
But my mom is amazing. And she did a lot of research. She actually snuck into a class for radiologists to read Cobb angles on x-ray. So she could read my Cobb angles. So she did a bunch of research and she actually found Dr. Larson from a YouTube video from a father who posted his daughter's scoliosis journey. And I believe mom found Dr. Larson from that YouTube video at the Mayo Clinic where she was doing a clinical trial just at the right time. She called her and said, I believe I have a candidate for your clinical trial. I was the perfect candidate. I was young. I had a primary and secondary curve that met the requirements of her trial. By the time I had surgery, I was 0.1 away from not being able to. My curve was at 49.9 and her cutoff was 50.
Wow, it's almost like, somebody was watching out for you.
Yes, as a Christian, I do believe that my Father in heaven was looking out for me.
It is amazing that to this point, there haven't been many options. I mean, bracing, spinal fusion, and then now we're talking about VBT. So, how do you explain VBT to a patient?
So vertebral body tethering instead of one big incision, and big meaning like 10 inches. So instead of one central incision in the back, it's smaller incisions in the side. And we do it with a camera. If we're fusing down into the lower back, it's again an incision in the middle. If we're going to do a tether down into the lower back, it's kind of a mid-size, like 2-3 inch incision in the flank. So on the whole, it's like less muscle dissection with the tethering. And then instead of that solid metal rod, we put a plastic cord. So here is the example of vertebral body tethering. So again, there's still a screw that goes into each vertebra, which looks a little bit like a fancy hardware screw. And then there's a plastic cord that is connected. So instead of that solid metal rod, the plastic cord can allow for bending and mobility, and also allows for growth. Some patients with the tether are quite young, and they might grow 1/2 inch a year through their spine. And with the fusion, that area that's spanned with the metal rod cannot grow.
Michelle, this seems like a pretty big breakthrough.
It really is. I mean, when Dr. Larson mentioned growth, the concept behind vertebral body tethering was to provide this growth modulation. So as the patient is growing and their spine is getting longer, that tether then can adapt and straighten the spine using the patient's growth.
Actually can make the prop do it too. This is a very nice prop that actually was printed in our 3D lab. But then during the surgery, we pull on the cord a little bit to make the spine straighter. And then as the child grows, if it's working appropriately, the spine will continue to get better and straighter. But the timing is tricky. That's one thing we're learning with this surgery. It's very hard to figure out what time is proper so that the amount of growth matches the amount of straightening.
What are the success rates with this?
On the whole, we're seeing about an 85% success rate as far as not needing a second surgery, but 15% of patients on average need a second surgery. And then across the board, the amount of straightening we get, the amount of correction we get is less with VBT compared to fusion because it's just a little plastic cord compared to a 5 millimeter, 6 millimeter diameter metal rod. So it really creates a dilemma for the surgeon and a dilemma for the patient and the family. Is it worth the risk of more surgery? Is it worth the risk of less correction to have the tethering performed?
But it is something new that hasn't been around prior. Does it excite you because there is something that you can now fall back on if you wish?
Absolutely. I believe that many parents know what's best for their own child. And I hope that in my encounter with the families, I can educate them and provide options and help translate the best available evidence and the best available research to that family. And then the family is really making the decision. And it's quite challenging because the parents say, what would you do, Dr. Larson? What's your recommendation? And many times I leave them scratching their heads and say, well, drive home, think about it. Let's touch bases on the phone in a week or two. Take some time to process what we talked about. And then I find most families are able to come to a conclusion. Michelle and I and our collaborators, we have surgeon collaborators around the nation through her foundation. We did a big survey of patients that had the tether, patients that had the fusion, and most people were happy with the choice that they made.
Sloan was lucky enough to receive VBT. What was the decision like to go forward?
The decision was mine, actually. We kind of put them up, pros and cons list, 50-50. Looking at the opportunity to be able to compete at the level that I did in skating and riding, it was really a non-negotiable. And actually, we had a conversation at a ranch rodeo. It was the week before I went down for surgery. I looked at my mom on horseback and I said, Mom, what if I don't make it through my surgery? And she looked at me and she said, Sloan, if you make it through the surgery, your life is your own. And ever since then, I woke up from surgery and I hit the deck running. I never stopped. I've done things that I never thought I would do. I am a professional barrel racer that placed top 15 in a professional rodeo 2 days ago. I landed my axel in figure skating. It's just been incredible.
Wow, that is amazing. Thanks to VBT, Sloan was able to resume her normal activities, and she's a very busy young woman. How stressful, Michelle, to make this decision, right? Because there are so many factors to weigh. So, how do you help parents?
Provide them evidence-based information. The problem is, Kathy, Dr. Google can be quite overwhelming and dangerous at times because it may not be correct information that they're reading or learning. The goal of our foundation is really to provide that information on the latest research. And this is important for vertebral body tethering. Like you mentioned, it is a new option, but it still is under research, significant research that our group is doing to really understand that perfect patient selection.
You mentioned a decision-making tool that you've both worked on, that you've created. Where is that, and what can you explain it for us?
We started out with a project that was funded by the FDA about 5 years ago. And when Michelle and I first wrote the proposal and turned it in, the main proposal was just to do that survey that I just mentioned, surveying families and what do you prefer? Do you care about motion? Do you care about chance of needing a second surgery? And then the FDA actually asked us, can you take it a step further and can you make a tool that families can use? So we reached out to the Mayo Knowledge Education Research Unit, and we really did a very scientific, well-researched, well-tested tool that it has visual aids and it has cartoons and it takes patients and their parents through the decision-making process. And the tool is actually populated with data from papers that have been written and have been published, but in a way that's friendly. Nobody wants to peel open a medical journal and read a technical 13-page paper and try to decipher it. This is taking that data, having the experts look at it, review it, and then putting it into an easy-to-use format.
Yeah, and the concept with the tool is that it's shared decision making. So it becomes a process and a unique opportunity for the clinician to actually sit down and spend the time on all of the concepts that we identified from our survey study, which were the top things that patients were interested in. Which Noelle actually did an additional study to that because many of the clinicians in our collaborative group of surgeons were thinking in their mind, "Oh goodness, this is going to increase my clinic time threefold when I need to sit down and use this tool." And Noelle found that it didn't increase time.
The best thing is that the child spoke a little bit more. Oftentimes you come in and it's the parents, it's the doctor, we're talking about the teenager, even though they're sitting right there in front of us. And this tool is a way to kind of engage the teenager and ask them to give their opinion. It's a great opportunity to make sure the child has self-determination.
Yet they did an amazing job, really used their expertise to help us develop this tool and utilize the GoPro camera recordings of interactions between clinicians and patients to really understand how to make this the most effective so that patients are engaged and want to be engaged in this decision. It's a very important decision and they want to have some ownership of it, I'm sure.
And thank you then for the decision tool that you've created. That helps, obviously. I want to ask a quick question here about the value of collaboration in the research consortia. Michelle, that sounds like that is it's very rich in terms of collaboration and very important for you and the foundation.
Yeah, it's existed we just had our 30th anniversary of a collaborative group of surgeons that started in 1995 and just dedicate and volunteer their time to study patients. And then more recently have donated to our foundation to support our research and keep us going. It's amazing.
So we're talking about VBT, which is interesting. But I'm wondering, Dr. Larson, is there something else on the horizon that's also exciting you?
I think at this point, those are our two main options. There was one other device out there, posterior dynamic distraction, which is also being studied thoroughly and is continuing to be used in select cases. I think the most recent excitement has been how can we take the best of fusion and the best of VBT and combine them together. In general, we think the lower back curves are the ones that are more difficult to treat because we hesitate to fuse somebody's lower back. Most of your bending, your twisting, your lifting comes through your lower back. On the flip side, when we put the VBT into the lower back, those cords sometimes break more. We're putting more tension on that cord. So right now, I think a lot of the work is being done around timing of the surgery, which patients do best with the surgery, and is there a way for fusing part of the curve and tethering the other part to have the best of both worlds?
Is there a way to deal with this problem without a lot of screws, plates, and metal? Or is that just not feasible?
I think early detection is ideal, and trying to have the least amount of impact on the child's life. With early detection, bracing works. There's also a nighttime brace that's an option for some of the smaller curves. There's a lot of interest and excitement about physical therapy. I like prescribing physical therapy because it gives the child or the teenager ownership over their own body, and the child visibly gets stronger. The problem right now is that the evidence for the efficacy of physical therapy is a little bit mixed. So we're still studying it.
Did you have to go through physical therapy after surgery? I would presume you did.
The physical therapist really just got me up, got me walking, and we walked up and down the pediatric unit hallway. And after that, I went home. I knew my restrictions. I wasn't allowed to run, I wasn't allowed to jump, and I was not allowed to do strenuous physical activity. So for about the first 4 weeks, I just sat on the couch or in the hospital bed that my mom had put in our living room, and I sat there.
Do you remember, did you have another maybe x-ray or CAT scan of your back? Did you get to see then the changes?
Yeah. Actually, I have every x-ray, every CT scan, MRI that I've ever had. It was really crazy to watch how fast it grew. Because, I mean, in March, you'd look at it and you'd be like, is something wrong there? And then in August, people looked at it and they were horrified. But after surgery, the curve was still there. And then when I went back for my first post-op, it was smaller. And then I didn't go back to Mayo until my year post-op. And then it was even smaller. And then I went back for 2 years, and my back was basically straight. I went back for 3 years. Still holding up good. I mean, if someone was going to be hard on the tether, it was going to be me. I was riding. I was falling off of horses. I was getting slammed into fences. I was falling on the ice. I was just hard on it. I never gave it a second thought because I honestly would forget sometimes. I had that much mobility and I have no pain.
I'm sure you probably gave Dr. Larson heart failure if she knew what you were doing.
She has honestly been pretty great about it. She tells me all the time she's super proud of me and that she's super happy that I am as active as I am because, I mean, somebody's got to do it. Somebody's got to put it to the test. And I just found out last October that no matter what, my growth plates are closed and I will never have to have a fusion.
You clearly made the right decision for your life.
Yes, I honestly believe so. And I would just want as many kids to know about this as possible because I know there's another young athlete out there that just got told that they're not going to be a young athlete anymore.
What other advice would you give young folks listening to this, and if they're faced with the same decision you had to make?
Listen to your internal instincts. Listen to your parents. And listen to your medical professionals, but also make sure that you exercise every option. Go to every corner. Look for every option. This would never have been an option to me if my mom wasn't as dedicated to finding another answer as she was. My mom had my back, literally. And now this surgery is, I mean, we can tell people about it. I know the thought of, well, it hasn't been done as long as the fusion sounds scary. But it is an extremely amazing surgery for those who truly do believe that there is more for them than just being fused.
And here you are, because I can tell that your heart is with your horses and you swing your leg up over the saddle, you settle in, and you're moving with your horse, doing all that great stuff. You're ice skating. I mean, clearly you are living your life to the fullest.
I do everything I want. I've never had any restrictions. After those 8 weeks, it was just so freeing. I could do whatever I wanted. I'm planning on going skydiving in a couple months. I just live life every day to the fullest.
You are an amazing young woman. Thank you, Sloan, for sharing your story. What drives you forward, Dr. Larson? I have a feeling this is your calling.
I'm absolutely called to do this. And I love my patients and I love their parents and I love seeing them grow up and mature and watching the interactions and all the wonderful families that I take care of. Just really remarkable, wonderful families. I think my goal is to have the scoliosis have like zero impact on the patient's lives, right? The brace you saw, big impact. Surgery, medium impact. But I would just like if I could wave the magic wand and make all the scoliosis go away. That's my goal.
What are your drivers to help these patients, Michelle?
Focusing our research, our prospective multi-center research on outcomes of various treatments that have components that are very important to patients. So health-related quality of life, understanding what that looks like after either one of these procedures is critically important. And then disseminating results of research is really the best keys that you can give to a patient and their family to begin this decision-making process. And sometimes that literature, medical literature, can be very daunting and sometimes a bit hard to understand. So focus of ours has been to put these into short 2-minute infographic videos that they can digest the study and then go back and ask Dr. Larson about it next time they see her if they have questions. And she's obviously very open to helping patients understand. I just would like to thank Dr. Larson. She's an inspiration to me and many of the surgeons in our group. And now we have a shared decision-making tool on the Setting Scoliosis Straight website, which is just phenomenal. Thank you, Dr. Larson. You contribute so much to this area of research and in the care for your patients. You're just an inspiration.
So, Michelle, it's on the website so people can use it right now.
They sure can. We've only released it within our surgeons to kind of beta test at this point, just to see if there was any further edits that we need to do. But we want to track who uses it. And so we will have a kind of entry into the tool to log your information, not so we can keep it and use it, but just so we can understand and maybe reach back to people who have used it, clinicians and their patients and families, and get feedback and advance it and improve it in the future.
I have a final question, and it's this to Dr. Larson, because I know you've said in the past, if we're doing the same thing in 10 years, we've failed, because we know there are better ways to care for children. So what do you imagine the future treatment could be, say, in 10 or 15 or 20 years from now?
I would love to have earlier detection for the scoliosis. And as there's new technology and new innovations, this is something we should be able to pick up sooner for most patients. And then if we could hone in the non-operative treatment, whether it's bracing or physical therapy, and we can do that early and do it for a short period of time and have it be highly effective. And then if there is surgery, I'd like to offer patients that have a surgery that's safe and very effective and has very low complication rate, and they're able to go back to all their activities right away with a very low incidence of pain. There's quite a bit of pain with scoliosis. I think, again, our old document said scoliosis isn't painful, but a lot of people have back pain, shoulder blade pain, rib pain. So that's another real important area is how do we help all people overcome their scoliosis pain? Certainly when I did the long-term follow-up study and I brought back people in their 30 or 40 years after their treatment, a lot of those people have back pain. So how do we eliminate that type of back pain and teach healthy habits and have appropriate treatment strategies to eliminate pain?
Michelle Marks and Dr. Noelle Larson, it's been a pleasure. Thank you so much.
Thanks you, Kathy.
Thank you, Kathy. Thank you, Dr. Larson.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show's edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. The Mayo Clinic production team includes Hui Hong Ong, Margaret Shepard, Samantha Clarkson, Kara Mangold, Felipe Sosa, Kim Ona, and Bryn Sankey. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.